Kirsten, you have the last 15 minutes of this session, and you're going to speak about the role of primary health care in contributing this, and this is coming back to the question of can we do more in adulthood, correct?
Correct.
Thank you. 15 minutes.
I realise we're running a bit late, so I'll try and do it even quicker.
No, you've got 15 minutes.
I have, okay. The simple answer, I can't actually answer this question. And I'm going to take you through why I can't answer this question. This is just a reminder, and I guess it's just bringing back to the point that this is a societal problem, so it's children and adults. So this is old data now, looking at risk of diabetes for BMI category across different age groups. So if you're 18 and you're obese, your lifetime risk of diabetes is twice that if you're 65 and obese. And that's for men and women. And again, just to remind us, these data are pretty old now, almost 10 years old, and if we're looking at the top here, this is pre-diabetes prevalence across the age groups, diabetes. And so again, it's a societal problem. The Adult Nutrition Survey was adults of 15 and over, so we don't know what's happening with children, but we've heard today that diabetes is now being diagnosed in children. And I make this point because these people are being diagnosed in primary care, and it's a huge proportion of our population, about a third, so they must be making contact with primary care. So in New Zealand we have guidelines, and we've heard about guidelines, and these are the primary care handbook for cardiovascular risk assessment and diabetes screening. So people are being screened for diabetes in primary care in New Zealand, and I think that is where we have an advantage compared to other countries. There is that contact. But what do we recommend for these people? There's an assessment of possible diabetes and pre-diabetes through an HbA1c test, and that's our testing here in New Zealand now. Then what do we do with these people if they're diagnosed with pre-diabetes or diabetes? We give them general lifestyle advice. And then we have all our 9 or 10 messages that we give people. But what does that mean in reality? How do we advise our patients? And there was a good review in the BMJ a couple of years ago where this question was asked by Jamie Ard. Obesity in the US, what is the best role for primary care? And I think that question applies worldwide, and particularly here in New Zealand. And the best opportunity for broad-scale treatment of obesity may lie in the primary care setting. But questions still remain about the optimal role of primary care provider in the treatment of obesity and prevention of weight gain. And I think we've seen some illustrations today. This is the environment we live in, and it's increasingly like that. And I must take a photo at Dunedin Airport because on the stairway, on each step, it's got a message about how you can eat more food. So it's have a look when you go home, those of us who are going back to Dunedin tomorrow. And so again, I think this has been another theme that's come through. What do we eat as members of the public? No carbs, high carbs, pineapple juice, cabbage soup. And so we're left with our population that really is like this. And we hopefully will have published very shortly a paper under review from some work. And this is a quote from one of our participants. There's so much out there now that just totally throws you every which way, and you don't know what's right, what's wrong. Some of those are falsehoods out there. So these are the patients with pre-diabetes. They really just don't know where to go. And who gives them that information? This is another, I don't know if any of you have seen in the BMJ, they have patient experiences. And this is the experience of a woman, and she tells her story. And she's clearly overweight, and this is an experience with her doctor. I assume that he tells all his fat patients the same thing, without bothering to find out about their individual situations. This is someone who's been doing some exercise but wasn't actually asked the question. And it's a reality in New Zealand. I only heard last week, a woman I work with and a friend of hers just been diagnosed with pre-diabetes. Her advice was, go and check out Dr. Google. And that's a primary care practitioner in New Zealand. So I think it's a real problem. And again, if we look at our guidelines, if we started our cardiovascular risk assessment guidelines, 10% down the bottom, lifestyle advice. If your risk is between 10 to 20%, you get specific individualised lifestyle advice. If we then look at cardiovascular risk assessment of 20%, or you already have CVD, you get intensive lifestyle advice. And so as a practice nurse or GP, what does that actually mean? What's these guidelines telling me? And so there is that confusion out there. And so what has been done in this space in terms of translating the very good lifestyle interventions, good RCTs in the US, in Finland, China, and some subsequent ones in India, how have we translated that very good clinical advice around lifestyle advice into the real world? And this was a review comparing the program of the DPP with subsequent translational programs. And you can see if we're looking at the number of lifestyle sessions offered in the DPP, it's more than on the average of the trials that were included in this review. Similarly, if you're looking at the DPP, it's 100% individual advice. When it's translated, we get a variation, individual, group, or a bit of both. And where were those settings? Again, we've got variation. It might be in the community, it might be in a church, it might be in a clinic, it might be at work site. And the duration of follow-up varies. Maintenance, sometimes not. So maintenance is important with the weight loss. And importantly, who's actually giving that lifestyle advice? Is it the doctor, the nurse, dietitians, grad students, internet? And so again, variation. So when it comes to looking at the evidence, are we comparing apples with apples? I don't think so. And so this is another recent review which has looked at this this whole question about what is the translatable package. And there were 38 studies included in this review, and there were 16 that were conducted in primary care. But I went through each of them and had a look, and most of them, this was a primary care one, it was a dietitian and physiotherapist employed by the primary care centre. So was it the primary care providers that are giving that advice? And similarly, we had endocrinologists and some. Physiotherapies were quite commonly used, dietitians. So again, you've got this variability, and it's actually not the practice nurses or the GPs giving this advice in these particular programs. There was one I found that was recently published, and this wasn't a full study. It was an iterative process trying to work out what does that package look like. What are the components of that lifestyle program? What has been done is taking those different studies and looked at the effect of them on weight, and this was at the 12 month time point. So even though there's variability, there is still a good weight loss. So this was after 12 months on average, a 3.77 kilogram weight loss. That was in the US. This study looked at various programs from around the world, and again, not quite the same weight loss, but after a year it was about 2.3 kilogram weight loss. So there is the potential, but we want to know what that package looks like and what's most effective. And so the conclusions from these reviews and meta-analyses was that overall pragmatic diabetes prevention programs are effective, but wide variation in the type of intervention and effectiveness. There are very few studies which actually have looked at primary care nurses. I think I can count on one hand how many there are. And so we need more research is needed to establish what are the optimal strategies for maximising cost effectiveness, and we need to look at the longer term as well, and that's not news to anyone. And the important question, do these weight loss intervention programs actually translate into a reduction in diabetes incidence? And I don't think we really know that, not in the real world. And just out of curiosity, because I had trouble finding literature, I thought, well, I'll just put it in context, and I'm not saying bariatric surgery is not important, but if we want to try and answer some of these pragmatic, real-life questions, I think we need to put more energy into our primary care-based lifestyle intervention programs. Very few. So I think it's an area of research we really need to have to direct our energies, particularly, as I said, a third of the population are engaging with primary care anyway. So I think some of our key points that primary care providers are in a good position to provide weight loss, and they can have a significant impact on patients and their behaviours. But how that best is delivered, we don't really know. And easy solutions by producing more pamphlets and more guidelines might not be the best solutions moving forward. So I think we have a keen ingredients. We've got patients, doctors and nurses who are keen to give this information, but we don't actually know the right recipe. How many visits does a person need? And so through some HRC funding, hopefully we are going to answer some of these questions. We've done some preliminary work and it looks promising and exciting. I've given you some qualitative work from one of our patients. We've also interviewed nurses. We've come up with a particular structured package which seems to be well received by nurses and participants. But like you, Alex, we're going to try and answer some of those hard questions. Why can a particular lifestyle program work for some but not others? So we're going to be looking at the social support, sleep, and some of those difficult cultural questions. We might not be able to answer them, but we're going to give it a go. And I think, again, this is another thing that's come through the day. We've talked about ducks. But I think it's very clear from the talks today that we really do need to work together, and I think there's a consensus on that, and we really just need to make sure that we're all moving in the right direction. But who is our leader? And I think there is some evidence out there that really the government should be providing a good steer on this, and then we can follow more easily. So thank you.
Thank you, Kirsten. We have time for a couple of questions. Cleona.
Thanks, Kirsten. That was great. I wondered what your thoughts are around, there was a paper published, I think, late last year from the UK looking at a brief intervention in primary care, but it was really around referrals to Weight Watchers and whether or not you think that might be an approach that's worth considering here in New Zealand.
Can you repeat the question?
The question is about whether an alternative to seeing a primary care provider is a referral to Weight Watchers. From some of the work we are going to publish, that relationship with the nurse seems to be really quite critical. So I think there's some wider externalities and benefits from seeing your nurse or doctor. And again, these are stories from our qualitative work, and hopefully we're going to get this published. That the flow-on effect, while you see the index patient, I was up in the Hawke's Bay, we were doing this work, and one of our participants had sort of been in the program about 2 years ago and had seen his nurse, and he said, "This is great, my wife's now lost weight, my mukapuna are doing a great job." And so again, I think through talking to them, and Lisa very eloquently explained these co-design, you're learning more about the costs and benefits from doing this. I don't want to steal the thunder of one of my Master of Public Health students who've looked at the cost effectiveness from our program and included that question. So I won't steal her thunder. She's going to present it at the New Zealand Society for the Study of Diabetes conference in Dunedin in May, so that's a wee plug for that conference. So I will let you know after that.
Okay. Thank you. We'll take one more question. You both already, we'll take two questions. Louise?
Thank you. I just wanted to follow up on that comment from before. That paper was from Lancet by Paul Aveyard, and I think one of the take-home messages was that family doctors, even with a brief intervention, it's received well by their patients, and it's even received better, and the impact is better. There's somewhere that they can go to get some support, which in that case was a Weight Watchers intervention. But I think one of the messages you can take is it's possible to train doctors briefly to actually raise the issue in a way that's seen as sensitive and appropriate, that allows other treatment to have an effect. Now, I think the message could be, can that be the practice nurse or some other community activity? But family doctors play a really important role in raising the issue.
I would agree with that completely. I say I'd like to talk more about what we're doing, because what we've designed is a way that raises that question. We're now trialling with midwives that work with that. So. And
of course we use brief interventions for alcohol and tobacco, and very successful. Yeah.
But the other thing I should say is part of the cost effectiveness, we've taken the time. So yes, I appreciate it. Probably didn't answer that completely, but we've factored in the time and the number of visits.
And before we take the last question from here, I want to make sure there's no question burning from the 2/3 of the majority who haven't had the opportunity to ask a question. Anything from over there? I went to an auction recently. You've got it.
Kirsten, I was just following up really on the cost effectiveness. I know you've done the new pilot and don't want to talk about it, but what about in general for primary care versus some of the other approaches? Have they done those comparisons?
Didn't compare it because there's some literature out there. I guess the bottom line is that Deb concluded it was comparative, but it was very hard to actually make that comparison directly. But it's definitely on a par.
Has emerged from behind the column.
I speak that question very briefly. The dietary counselling ones in primary care, they're all over the place. Some of them are cost effective, but their overall health gain is much less than something done across the whole population. So Kirsten has exactly identified this area needs a lot more research than potential to tap in our clinical services.
Okay.
Thanks, Tony.
That draws this session to a close. Thank you all very much. I'd like to join you in thanking the speakers. And we will reconvene at 3:30 exactly. Thank you.